السلام عليكم ورحمة الله وبركاته. بسم الله الرحمن الرحيم. الحمد لله رب العالمين والصلاة والسلام على رسول الله صلى الله عليه وسلم. I'm Hesham Sheshtawy. I'm Associated Professor in Neurology and Psychiatry Department, and I'm so happy to be with you today. First of all, start to gather good intentions as much as we can and to pray for ourselves and for others, hoping that Allah will respond to it, inshallah. Okay, today, inshallah, we are going to talk about one of the great blessings of Allah. Really, it is a great blessing, but put in your mind that it must not be requested from Allah. So it is a blessing, but we have to avoid asking for it. Contrary to that, we have to ask for being away from it, inshallah. And if we was subjected to something like that, we have to search for pushing it away from ourselves. But actually, when it comes to us, it's a blessing, but avoid asking about it. What this blessing is: an anxiety and related disorders. First of all, let's say why we are studying certain topics in medicine in general. Why we are studying certain diseases. To study certain illness, this illness or disorder must be prevalent, must have bad impact psychologically and economically and physically. It's better to be treated. Some sort of treatment are available. If we have these criteria present in certain illness, so anyone dealing with a patient have to have an idea about it. These 3 points can be applied for a lot of psychiatric disorders, and one of these disorders, or one of the group of these disorders, are anxiety and related disorders. For psychiatric illness itself, we have an additional criteria that is you can say that it is peculiar for psychiatric disorders, which is that psychiatric disorders are underdetected and improper and have improper attitude. And this can be applied a lot regarding anxiety and related disorders. Of course, you observe that we're putting a line under related and the letter S. Why? Because after 2013, some sort of changes have occurred in the classification. It is not a big deal to have an idea about it, but we have a different classification system that separates certain anxiety disorders from the previous classification and put another disorders in it. It is not a big deal for you, but if you want to hear about it, okay, no problem. And you observe, of course, the letter S, because anxiety disorders, it is not a single disorder. It's different types, as we are going to see. Anxiety disorders are prevalent, has bad impact, can be treated, and it is underdetected and have improper attitude. Why these disorders occur? Actually, we can say with big sure that, of course, an anxiety disorder is caused by blah blah blah. No, but we have theories. Mostly, it is related to interaction between biological predisposition, like genetic predisposition, and psychosocial factors. This interaction between biological and psychosocial factors mostly is responsible for the development of anxiety and related disorders. Put in your mind a very important piece of information. This is one of the most important ideas that I hope that it will be implanted in yourself, that it is not a weakness. An anxiety disorder cannot affect weak people, because an anxiety is a hard training. It's a hard, and also it's a hard way of correction of pathway. So this hard training means that the trainer is strong. Why it affects some of the strong people? Of course, not all strong people must be affected by generalized anxiety, by anxiety disorders. But the contrast is right. All those people who are affected by anxiety and related disorders, and by the way, by depression also, must be strong people. And it affects them as a way of training to make them more stronger. Why to be stronger? To be happy more, inshallah. So the idea that an anxiety is a sign of frailty, is a sign of weakness, this is totally wrong. It's a way of training. It is a harsh training. It's a hard training. That's why it cannot affect weak people. So put in your mind this equation: P equal P. Pain equal power. Whenever we are saying that this man is suffering from pain, this means that this pain is a way of training, and this training is hard. So this trainer is strong. Put this piece of information in your mind. This is very, very important. Now, what are the clinical features of anxiety and related disorders? Generally speaking, we have excessive fear or anxious mood. Some of the literatures try to differentiate between fear and anxious mood, and sometimes they can be used interchangeably. So it is not a big deal to say fear or anxious mood. But the important point here is that it is excessive and present almost always, most of the time. Almost always, most of the time. How to say that this is excessive? What's the measure of excessive? We have 3 items to measure this excessiveness. Number 1, it is a change. So this is not me. I became excessively anxious more than my usual. Okay, all of us have fear. All of us can have fear as an emotion, and it's important for us to cope with life. But if it become a change, this is not my usual. I have usual fear, and for a while now I have excess fear, more than my usual, for a prolonged duration, not for 1 to 2 days. No, it's a prolonged duration. And it affects the quality of life. It affects my activities. It affects my concentration. It affects my relations. By presence of these 3 items in the fear or anxious mood, so this is excessive. Put in your mind that in anxiety disorders, insight is intact. The patient knows well that he is suffering from an illness, and his illness is psychological in origin, and it needs treatment. Mostly the patient say that. And psychotic features are absent. So no delusions, no hallucinations are present in anxiety disorders. This means that if I have a patient that was diagnosed by certain type of anxiety disorder, and later on he started to develop delusions or hallucinations. Delusions, false fixed beliefs that cannot be reasoned, not related to the culture or religious background of the patient, or developed hallucinations, perception of non-existing stimuli. Don't say that these delusions and hallucinations is a sort of exaggeration of this type of anxiety, or it is a worsening of this type of anxiety. No, the patient actually developed a new illness, another disorder, another psychotic illness. Okay? As we said, that anxiety disorders have different types. These types differs according to the predisposing or the precipitative for this fear or anxious mood, for this excessive or fear or anxious mood. Differs also from each other according to the severity of the somatic symptoms present. The course of anxious or fear mood differs. Accordingly, we have different types. These types, number one, we have generalized anxiety disorder, in which the patient have excessive fear from almost always everything for a prolonged duration, for mostly more than 6 months. Somatic symptoms is not so evident. Sometimes the patient can feel muscle tension, fatigue, but mainly the patient suffer from excessive fear, sometimes irritability, easily provoked to anger, easy fatigability, diminished concentration, catastrophic thinking, insomnia. Mostly this insomnia is of early type and interrupted type. We have another type, which is panic disorder. Panic disorder, in this disorder, the patient suffer from successive or different or repetitive episodes of panic attacks. At least 2. And at least these 2 of panic attacks comes unexpected. What are panic attacks? It's a group of symptoms in which the patient suffers from severe fear. Severe fear. It reaches its peak within 10 minutes. Usually remains for about half an hour, something like that. Not more than 1 hour. Rarely to continue more than that. And then it subsides. But during this severe fear, the patient suffers from different somatic symptoms, like palpitation, like chest pain, like choking sensation, like tremors, trembling, shaking, like paresthesias, like hot flushes, like sweating, lightheadedness. The patient may think that he's going to be crazy, to lose his control. He's going to die. Sometimes the patient suffers from depersonalization and derealization. Depersonalization say that I feel that I'm strange, or the surrounding is strange. This is the derealization. Of course, not all these symptoms have to be present, at least 4 of them. This is the panic attack. To say that it is disorder, these panic attacks have to be 2 or more, and 2 or more of them, 2 of them at least, to be unexpected. Unexpected means that out of the blue, I was fine. Suddenly, I start to suffer severe fear. I can't take my breath. I have severe rapid heart rate, tremors. I feel that I'm going to die. I start to scream suddenly, out of the blue. Not I'm imagining that. In this situation, I'm expecting that I'm going to suffer from this attack. This is expected attacks. No, it can occur in panic disorder, but at least some of these attacks, 2 at least of these attacks, have to be unexpected. To say that these panic attacks, panic disorder, in between the attacks, the patient must to suffer for at least more than 1 month. Now the panic attacks stopped, but I'm thinking excessively about it. I'm avoid going out of it. I'm searching for, I'm asking for help from different doctors, like cardiac doctors, because I feel that I'm going to have a heart attack. So it affects my behavior in between the attacks for more than 1 month. So repetitive panic attacks plus the affection of quality of life in between the attacks that affects my behavior in between the attacks. So this patient is going to be diagnosed as panic disorders. If we have no affection in between the attacks, it is just panic attacks, not panic disorders. Social anxiety disorder, in which the patient have marked and immediate fear in social situations. like talking in front of others, especially if they are strange, eating in front of others. Why? Because he have an idea that they can embarrass me, they can humiliate me. He knows that this is irrational, but he can't prevent himself from feeling these feelings and thinking like that, although he knows that it is irrational. And it leads to avoiding of these situations. Avoiding of these situations. And it usually remains for a prolonged duration for more than 6 months. Specific phobias. Marked and immediate fear from certain items. I know it is irrational and I don't know why I'm feeling that. Like animals, feeling excessive fear of cockroaches, for example, mice, fear of heights, fear of injection or needles or blood. I know it is irrational. So if I said for you that this animal is an advanced tool that can withdraw my thoughts from my mind, and I'm sure of that, this is delusions. This is delusions. This is not specific phobia. In specific phobia, the patient, okay, no, I am going to avoid this injection because I have excessive fear. I can't go upstairs and look from the 14th floor balcony because this makes me suffer from excessive fear. So I'm avoiding it for a prolonged duration, again, for more than 6 months. And I know it is irrational. I don't know why. I know it is irrational. Another type of anxiety disorders, agoraphobia. Agoraphobia is feeling of severe and immediate fear when I'm outside the home or in a crowded place or an open place or a closed place. Why? Because I have an idea that if something bad occurred to me, if something bad occurred to my health, how I am going to be rescued. I know it is irrational. Again, all these ideas, I know it is irrational. Put in your mind, agoraphobia differs from specific phobia. In that specific phobia, of course, I have fear of cockroaches, and I don't know why. In agoraphobia, I give you explanation, and I know it is irrational, but I can't prevent myself from thinking like that, from feeling like that. Okay, again, this occurs for a prolonged duration, more than 6 months, and it leads to avoiding these situations. So I'm not going to go out of my home unless someone come with me. But being away from my home, no, it is very difficult to me. Okay, we have other types present in anxiety disorders, but this is the most of the famous types. Other types you can read about it if you know, but this is one of the most important types. We have other types that was present in the previous classification in anxiety disorders, and it was separated and become a different disorder in the recent classification. That's why we are saying related disorders to anxiety. One of them is OCD, obsessive compulsive disorder. In obsessive compulsive disorder, we have obsessions and or compulsions with it. Obsessions is recurrent, repetitive, intrusive ideas, impulses, images. I know it is irrational. I know it is a product of my mind. I know it is excessive, but I can't stop it easily from my mind. And their presence causes marked distress to me. It can be ideas like checking. I want to check whether I closed the door or not. I didn't close the door. 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 Repetitively. Sometimes these ideas can be related to Allah Subhanahu wa Taala, even insulting Allah Subhanahu wa Taala, even insulting prophets. I know why I'm thinking like that. What are these thoughts? I became atheist? Of course not. I have sinned? No, of course not. By the way, those who are suffering from obsessions like that, they are taking hasanat from Allah Subhanahu wa Taala because they are suffering. I'm not intentionally doing that. I'm suffering from it. Sometimes in most of the times, actually, repetitive acts, physically or mentally, start to occur in a trial to minimize the anxiety associated with these obsessions, not implementation of obsession. Actually, the patient is not going to implement the obsessions, inshallah. But he is trying to minimize this anxiety associated with the obsessions. So now I have an idea, repetitively, intrusively, that my hands is contaminated. My hands are contaminated. My hands are contaminated. My hands are contaminated. My hands are contaminated, repetitively. And I can't stop it. Now I'm going to try to wash my hands with a specific order for a prolonged duration. To say that it is obsession or compulsion, it has to be time consuming, that occupies more than 1 hour per day, most of the days of the week, for a prolonged duration again. Okay, so repetitive washing of my hands, this is a compulsive act. This is a compulsive act. And the disorder is obsessive compulsive disorder. Mostly the patient knows that these ideas are irrational. He can't prevent himself. By the way, a lot of researchers said that if the obsessions start today, when the patient go to the doctor, this gap between start of the illness and searching for the treatments can be from 3 to 10 years. Why? Why this prolonged duration? Because the patient has absent knowledge that this is an illness. If I said to him, this is an illness, go to the doctor, he will say, oh, thank you. I'm suffering for a prolonged duration. Thank you. And he by himself is going to go to the doctor asking for help. Also, one of the last item I'm going to talk about it in the clinical features. It was present in the previous classification as a part of an anxiety disorder, and now it is separated. This is PTSD and ASD. This is post-traumatic stress disorder and acute stress disorder. In post-traumatic stress disorder, the patient is subjected to severe traumatic events, rape, accident, fire, or see one of his beloved person subjected to this event, or, for example, he's one of the firemen or subjected for repeated exposure to dead bodies and something like that. After witnessing this trauma for more than 1 month, the patient starts to suffer from certain group of symptoms. First group of symptom is repetitive, intrusive thinking, memories about it. He's memorizing the traumatic event a lot. He's dreaming of it. And sometimes he enters in a dissociative state, which is called flashback. Dissociation means that I am separated from my real and start to act as if I am in the accident now. This is called flashbacks. Number 2 of the symptoms is avoidance. I'm avoiding place of the trauma. I'm avoiding the place of the accident. And as a part of this avoidance, we have a third group of symptoms, which negative cognition and emotions. If feeling helpless, feeling that I'm bad, thinking that I'm bad, I'm responsible for that, I'm blaming myself from this for this accident. The future is bad. Feeling sometimes numbness and nothing, detached from the surrounding. These are negative consequences of the trauma. And lastly, hyperarousal state. Hyperarousal state. Hyperarousal state in the form of irritability, is startled, easy provoked to anger, hypervigilant. He can't sleep easily. Of course, not all those who are subjected to traumatic events are going to suffer from PTSD. To say that they are suffering from PTSD, they are suffering from this symptom for more than 1 month after the trauma. It can start immediately and remain for more than 1 month. It can start after 1 month and remain continuously. If these symptoms start within 1 month after the trauma and stopped, this is acute stress disorder. To say that it is post-traumatic stress disorder, this group of symptoms have to remain more than 1 month, or even started after 1 month of the trauma. So he remains after the trauma very nice, not suffering from anything, and then start to suffer after 1 month. So this is post-traumatic stress disorder. You can see more details about it in the text, but this is just general ideas about the main features of the different types of anxiety and related disorder. Now, we have differential diagnosis. The word differential diagnosis means that what we are going to say is have some sort of similarity between anxiety and related disorders, but have other aspects of difference. Number one is normal fear. We have fear here, and we have fear in the anxiety disorder. But as we said, to say that it is anxiety and related disorder, it has to be excessive. And excessive means we have a change from my usual for a prolonged duration that affects my quality of life. Number two and number three is very important to say that this anxiety and related disorders are primary psychiatric disorder. You have to exclude that this anxiety and related disorders is not due to another medical condition. So it is not due to hyperthyroidism. It is not due to pheochromocytoma. It is not due to myocardial infarction. It is not due to a type of epilepsy. It is not induced by substance like marijuana, like cocaine. It is not due to them. Okay? So it is very important to exclude that it is not due to another medical condition. It is not due to substance. Previously, the psychiatric symptoms due to another medical condition or due to substance was said to be organic under the title organic. It is not so precise because actually primary psychiatric disorders have organic changes in the brain. That's why this word is not used in the text now. If we said it, just we are saying it as a form of simplicity. But the precise word, it is anxiety disorder symptoms due to another medical condition or due to substance. So as a part of the differential diagnosis, to say that this is a generalized anxiety disorder, you have to exclude that it is not due to another medical condition. It is not due to the active effect of substance. And this can be applied for all types of anxiety disorders. Also, as a differential diagnosis, if you are dealing with a patient of generalized anxiety disorder, for example, you have to exclude that it is not due to other types of anxiety disorders, to differentiate from other types of anxiety disorder, like specific phobias, social anxiety disorder, panic disorder. You have to differentiate it. And as we said, they differ from each other according to the precipitator of this excessive fear, or the way of the presentation of this fear, the prevalence of somatic symptoms, and so on. Lastly, you have to differentiate anxiety disorders from anxiety symptoms associated with other disorders. For example, psychotic disorders like schizophrenic patients can suffer from anxious mood, excess fear. But this excess fear is not diagnosed as generalized anxiety disorder. It can be fear related to his delusions or her delusions or his hallucinations. Demented patients, for example, those who are suffer from recent amnesia and other neurocognitive symptoms, can have an associated symptom of anxious mood. This anxious mood is not diagnosed as generalized anxiety disorder. It is just anxious symptom of the dementia. So differentiate from an anxiety disorder and anxiety symptom in another psychiatric disorder. Put in your mind that comorbidities between different types of anxiety disorders are very common. So it is very common to see a patient suffer from generalized anxiety disorder and panic disorder and social anxiety disorder with each other. It is common to see a patient suffering from obsessive compulsive disorder and generalized anxiety disorder. And also, it is very common to see that these types of anxiety disorders are comorbid with depressive symptoms or even major depressive disorders. It's very common to see these comorbidities in the same patient. Okay? Now, how to assess this patient? The way of assessment in medicine start with history, of course. In psychiatry, we do mental state examination and physical examination to exclude that it is not due to a general medical condition or substance, and to do investigations. Why we are doing this assessment? Number one, for differential diagnosis, for exclusion of the differential diagnosis. It is not due to the general medical condition. It is not due to the active effect of substance. It is not a symptom in another psychiatric disorder like schizophrenia. Also, we do assessment for treatment choice and follow-up. Now I'm going to plan a certain type of treatment. To plan this treatment, we need this assessment. We need an intervention for biologically and psychosocially, as we said, for the cause. Biologically, we need drugs, for example. What is a suitable drug for it, for this patient? We need assessment for that. Also, we need assessment for associated conditions. And in this point, it's very important to put in your mind a very important piece of information. And this is the second most important piece of information that you have to put in your mind in psychiatry. The first piece of information is P equal P, pain equal power. It is not a sign of weakness. Number two is respect somatic complaints. Respect somatic complaints. Respect somatic complaints. What I mean by that? Before saying that the somatic symptom complained by the patient is part of his disorder, of anxiety disorder, you have to exclude that this somatic complaint is not due to a comorbid medical condition. So if the patient is suffering from headache, don't say that this headache is a part of an anxiety disorder. Before saying that before excluding that this headache is not due to another medical condition, like migraine, for example, like whatever the cause of headache. Yes, of course, the somatic symptoms is very prevalent in psychiatric disorders and in anxiety disorders. But please, before saying that this somatic symptom is a part of the psychiatric illness, you have to exclude that this somatic symptom is not due to another medical condition. It's not due to comorbid medical condition present in the patient. So it is very important to respect somatic complaint. To respect somatic complaint. And lastly, for the causes of assessment, it's just for medical legal reasons. Sometimes it is important for us. Put in your mind that in anxiety disorders, we have no diagnostic tests. Sometimes we do some psychiatric, psychometric assessment by certain scales, like, for example, big anxiety inventory. These scales assess the severity of the anxiety. It is not diagnostic. So the main way of diagnosis is clinically, and to exclude differential diagnosis. And to exclude the somatic symptoms is not due to another medical condition. No, so now I said that this patient is suffering from generalized anxiety disorder, for example, social anxiety disorder. I can do psychometric tests by a psychometric scale to assess the severity of this condition, but I'm not diagnosing it with this scale. So till now, we have no diagnostic tests for primary psychiatric disorder. That's to say, for example, I'm going to ask for certain imaging of the brain, and if I find the finding blah blah blah, so this patient is suffering from generalized anxiety disorder. No, till now it is not available clinically. Experimentally, yes, we have research for that, but it is not present experimentally or clinically. Sorry. And lastly, treatment. How to treat? In talking about psychiatric disorders, we have 4 items in the treatment: hospitalization, ECT, electroconvulsive therapy, psychotherapy, and psychopharmacology. Usually, we do hospitalization whenever we have danger for the patient or for others. That's the main indication. And that's why mostly we don't need to hospitalize an anxious patients, unless this patient, for example, suffering from suicidal thoughts, and by assessment of his suicidal risk, I found that this suicidality in the patient is of high risk, so he needs to be hospitalized as a protection from himself. But this is not usual. So usually we don't need hospitalization. What about ECT, electroconvulsive therapy? In generalized anxiety disorder or other types of anxiety disorders, usually it has no effect unless the patient is suffering from suicidal symptoms or comorbid depression resistant to treatment. I can do ECT for this suicidality or for comorbid depression, but not for anxiety disorder itself. By the way, an anxiety disorder is very, very, very beneficial